The patient has been on controlled ventilation for several days. Now they look like they're assisting, there's breaths coming in, and you think, wow, it's time for this patient to go on a spontaneous mode. You turn them over to spontaneous ventilation and nothing happens. After 30 seconds, a backup rate appears. What's going on here, and why is the patient not triggering the ventilator? This is a series on monitoring mechanical ventilation, and this tutorial is on triggering. This time I will discuss under-triggering and over-triggering, understanding and using flow triggering, and using IE sync as an alternative trigger. You're rounding in the ICU and you come to the bedside of Chris, who's a 46-year-old male who has been in for a while, having had COVID pneumonitis with a history of lymphoma. He then developed ARDS and he was paralysed and prone, and now he has been weaned to VC plus ventilation. This is volume guaranteed pressure control, otherwise known as pressure regulated volume control. It's an assist control mode. And when you look at his ventilator screen, you can see this A up in the top left-hand corner. Every ventilator has this somewhere, you just have to look for it. And that means that the patient is assisting some of the breaths that he's getting. So that's happening quite frequently. And that means he is triggering the ventilator. Because of this, you decide, well, it's time to change him over to a spontaneous mode. And let's see what happened. And this is what you see on the screen. There's nothing there. No breaths. Nothing happening. No positive pressure. Maybe there's an occasional breath. Then after 30 seconds, the rescue mode commences. Then there is some purple face coughing. Sedation is given to the patient and he's back in a control mode, and you've made 2 steps back. Well, how did this come about? It looked like he was breathing, but he's not breathing. What's happening here? This is what his waveform for pressure looks like. You can see there's a standard pressure support breath, and then after that there's a divot. Then there's another divot. And then if you look at the flow waveform, there's a big divot there as well. And what's going on here is that Tim is trying to trigger the ventilator, but the ventilator isn't triggering. And we call this asynchrony. This is not a term that I have used previously in this course, and I'm quite pedantic about my use of English. Asynchrony from this point onwards will refer to a situation where the patient is attempting to breathe, but not every breath is detected by the ventilator, or the ventilator is detecting breaths that do not exist. So the ventilator is triggering, giving the patient a breath, but the patient isn't actually breathing, and this is a problem of triggering. I've used the term dysynchrony quite a lot, and dysynchrony occurs when there is dysfunctional interaction between the patient and the ventilator. It occurs when the flow is too fast, it is too slow, it's too long, or it's too short. And these are all problems of flow control. We're going to focus on triggering. The patient is taking too few or too many breaths. Tim is put on pressure support ventilation with the pressure support inspiratory pressure level of 10, a Vsens of 5 liters per minute, that's the flow sensitivity, and expiratory sensitivity of 25%. Let's see what happens. What do you think is going on here? Clearly this is pressure support ventilation, the red waveform with the little nip on the top and then a flat surface tells you it's pressure support, so the first breath looks normal. But there's something missing. These 2 breaths here are not being triggered. So the patient is trying to breathe, but not every breath is happening. The patient is asynchronous. They are under-triggering. To understand what's happened here, we need to go back and revisit flow triggering. In this cartoon, I have drawn a patient who's a pink blob with a tube sticking out of them attached to a ventilator. And the ventilator has an output valve and a return valve, and in these valves there are flow sensors. Gas flows around this system continuously, and that's known as flow by. And on the Puritan Bennett ventilators, there is 1.5 litres of flow going around the ventilator all the time, whether you like it or not. And that is known as the base flow through the circuit. Now, you can add more flow to this as part of the triggering mechanism. And that flow may be 2 to 5 litres above the base flow. And that's known as the Vsens. And the Vsens plus the base flow is known as the bias flow. This is done differently in other ventilators. Some ventilators only have the 2 litres or 3 litres of bias flow and nothing else without the base flow. Or sometimes there's just a base flow and nothing else. Irrespective, this is what it looks like on the screen. So the base flow is always 1.5 litres per minute. Above this is the Vsens, that's the flow by. So here we have 3 litres of flow by. The bias flow is the flow by plus the base flow. So what's the bias flow here? In this situation, it's 4.5 litres. And that's important, and I'll get back to it in a couple of minutes. Now, how flow by works is that the patient takes a breath, and that flow that's going through the system is detected by the ventilator. So the return flow is lower than the outflow. And if the recovered flow is less than the base flow, then the ventilator will trigger a breath. If there's 2 litres of flow, that's a low flow system, a small breath will have a major impact, and it is easier to trigger the ventilator. So if the patient has a weak bellows, they will trigger the ventilator more easily if the flow is low. However, if the flow is high, like 5 litres per minute, as in Tim's case, a small breath will have minimal impact, and it is harder to trigger because of the strong bellows. What does 3 litres per minute actually mean? Well, it means 3,000 mils per minute, or 3,000 mils every 60 seconds is 50 mils per second. If the patient's spontaneous inspiratory time is somewhere between 0.5 and 1 second, for a 1 second spontaneous inspiratory time, the flow demand for a 3 litre trigger is 50 divided by 1, or 50 mils. How much volume must be inhaled to trigger if the spontaneous inspiratory time is 0.8 seconds? That works out at 50 mils divided by 0.8, which is 62.5 mils. So, the shorter the spontaneous inspiratory time, the greater the volume required to trigger the ventilator. In this particular case, the Vsens has been set at 5. Now that is really high. That's what you do for someone who is really triggering the ventilator a lot. They're very strong. They've got powerful bellows. So this is not great. And this is what 5 litres per minute actually means. 5 litres per minute is 5,000 mils in 60 seconds, or 60 mils per second. If the spontaneous inspiratory time is 0.5 to 1 second, for 1 second spontaneous inspiratory time, the flow demand for a 5 litre trigger is 60 divided by 1, or 60 mils. How much volume must be inhaled to trigger if the spontaneous inspiratory time is 0.8 seconds? Well, the answer is 60 divided by 0.8, or 75 mils. That's more, and that's higher, and that's why it's harder to trigger the ventilator, because that larger volume over a shorter period of time makes it very hard for the patient to actually acquire a breath. So the trigger sensitivity on a Puritan Bennett ventilator is based on a specified volume drawn to trigger. If it's a 2 litre sensitivity or a 5 litre sensitivity, there's a big difference. The 2 litre is low volume and it's easy to trigger. The 5 litre is high volume and it's harder to trigger. And what actually happens is this. If you set the Vsens at 5 litres per minute, the base flow is 1.5 litres per minute. This is just a clearinghouse around the machine. And you have a difference of 5 litres between that base flow and the bias flow, okay? So the bias flow is 6.5 litres. We're going to colour these in now. This red zone is the base flow, and this yellow zone is the bias flow. And the patient has to breathe in from above the yellow zone down into the red zone to trigger the ventilator. Let's have a look at this. There's two breaths. The first breath doesn't get down to the red zone. As a consequence, the breath isn't triggered. The second breath does get into the red zone, so the breath is triggered. If we turn the flow by down, in this case, we set the Vsens at 3 liters per minute, that yellow zone is much shallower, so it's significantly easier for the patient to trigger the ventilator. So the lower the flow, the easier it is to trigger. If the patient has rapid shallow breathing, for example, a frequency divided by a tidal volume in liters of more than 100, do you increase or decrease the Vsens? Let's work the problem. If the respiratory rate is 30 per minute, the tidal volume is 280 mils, the frequency divided by the tidal volume in liters is 30 divided by 0.28 or 108. This is marginal at best for weaning a patient. The Vsens at 3 liters per minute is 50 mils per second. Assuming that the ITE ratio is 1 to 2 or 1 to 3, 30 breaths over 60 seconds is 2 seconds per breath. The inspiratory time is 0.66 to 0.5. As the rise time has to be less than 0.2 seconds or less, the time to trigger is very short. If the Vsens is set at 3 liters per minute, the patient needs to take 50 mils to trigger, or 18% of tidal volume. Reducing the Vsens to 2 liters means the patient has to take 33 mils, or 12% of tidal volume. So if the patient has rapid shallow breathing, reduce the flow by, reduce the Vsens above the base flow, and increase, if necessary, the pressure support inspiratory pressure level. Now in this patient, he started off at 5. We're going to drop the Vsens to 2 liters per minute and see what happens. What do you think is going on here? Well, what is happening is the patient is now over-triggering. He's triggering the ventilator way more than he should, and it's going to cause breath stacking. And when you have breath stacking, you have auto-PEEP. And we discussed this when we discussed the flow waveform. So we need to make an adjustment. If we started at 5 and he was under-triggering, we started at 2 and he was over-triggering, there must be a happy medium in between. So we'll change the Vsens to 3 liters per minute and see what happens. And now we have perfect patient ventilator synchrony. Now, there are alternative ways of doing this, and the alternative way of doing it is to use a pressure trigger. Back in the day, pressure triggering was how patients triggered the ventilator. The patient took a breath in, they generated negative pressure in the circuit way down on the inspiratory limb, and that caused the ventilator to trigger. And flow-by was brought in to make it easier for the patient to breathe. But it's worth knowing that most ventilators have pressure triggers. And for example, this is the trigger that you will see on the servo I ventilator, and it can be set from 0 to minus 20 centimeters of water. The greater the negative number, the harder it is to trigger. And you'll see a purple color indicator on the pressure waveform on the servo when they're on, for example, pressure triggering. And if it's flow triggering, you'll see that little purple indicator on the flow waveform. So let's have a quick look at negative pressure triggering. In this example, I have the airway pressure on the left-hand side on the y-axis, and you can see that I've drawn in PEEP, which is at 5 centimeters of water, and below that there's a red line that represents the negative pressure trigger, and I've set it at -1. So the patient, in order to trigger the ventilator, just has to generate -1 centimeters of water of airway pressure to get a breath. Let's see what happens. Well, this is not good. You know this picture now, having seen it early in this tutorial. This is over-triggering. So what are we going to do? We've got to make it harder for the patient to breathe. So we need to spread that negative pressure trigger downwards. So we might get a bit all extreme on the patient and send it down to -4. And let's see what happens here. Oh, this is clearly terrible. This patient is totally under-triggering because they can't suck in enough negative pressure to activate the ventilator. So let's put it back up to -3 and see what happens. Well, the patient here is clearly gasping and getting a few breaths, but there's lots of breaths being missed and the patient is very uncomfortable and they will look dysynchronous with the ventilator and they will get all purple-faced and people will start loading up syringes of sedation. Not good. All you need to do is move along and push up that negative pressure trigger to -2 and let's see what happens. And now we have a happy patient. Triggering can be a little bit difficult. It can be tricky. Sometimes patients will trigger, sometimes they won't. And we don't really know for sure when the patient is starting to activate the breath. Some patients are very weak if they have a polymyopathy of critical illness, for example, or they've had a stroke or a brain injury. And sometimes that diaphragm just doesn't work very well. A number of novel approaches have been proposed and adapted to help patients trigger the ventilator, but a lot of them are quite intrusive. A less intrusive approach is now available as a software upgrade on some ventilators, on the Puritan Bennett ventilators and the Hamilton ventilators in particular. On Puritan Bennett, it's known as Sync. On Hamilton, it's known as IntelliSync. And this is an algorithm-based technique for determining onset and offset of spontaneous breaths using complex mathematical models in conjunction with the excellent pressure and flow sensors. It's being marketed to replace two components of the settings on the spontaneous breathing modes, pressure support and volume support. Now I want to draw your attention to this column that controls inspiratory triggering in all assisted modes and expiratory cycling in pressure support and volume support. There are now 3 triggering options: flow triggering, pressure triggering and Sync. This is what pressure triggering looks like on this particular column. And this is what Sync looks like. Let's go back to this patient. This is the scenario of Chris, who developed COVID pneumonitis and ARDS and is now trached and recovering slowly. Unfortunately, we have failure to trigger the ventilator, and this is a major problem. We've already tried and failed with flow-by, and as you can see, we are currently failing with pressure triggering. This is his flow waveform. Now what we are going to do with him is put him on Sync. Now you can see on Sync, this is much better. He's now triggering most of his breaths, but there's still a breath that hasn't been triggered. So we're going to go and have a look at what we can do to help him trigger. On the inspiratory side of Sync, we call it Sync. And if you turn the knob to the left, to either the first or the second chevron, you get more sensitive triggering. If you turn it to the right, you get less sensitive triggering. So in Chris's case, are you going to turn it to the left or are you going to turn it to the right? We're going to turn it to the left. And the reason why we're going to do that is because he's under triggering, so we need to increase the sensitivity. So we went to -1 on Sync, and you can see that clearly the ventilator is still not picking up each breath. So let's roll it on and click it one more time to the left and see what happens. And you can see, clicking further to the left, we are now synchronizing perfectly. And this is a beautiful picture for someone who started off only getting 1 breath in 4. As a consultant in ICU, my goal is to move patients progressively towards liberation from mechanical ventilation. The problem is, if the patients aren't triggering the ventilator, they end up on control modes from which they're often dysynchronous, and as a consequence of that, they get sedated and their body starts to decondition. Any technological advance that helps the patient interact with the ventilator as they recover from their polymyopathy of critical illness is a major advance. Finally, I want to cover the most forgotten and misunderstood cause of failure to trigger. It is an issue that I believe occurs far more often than is appreciated, and it is rarely looked for at the time that the clinicians believe that the patient is ready to wean. That is the problem of Auto-PEEP. You need to understand that the presence of Auto-PEEP makes the mechanism of triggering, whether it's pressure, flow, or Sync, redundant. Because in essence, the patient is unable to move sufficient air despite their having a strong thoracic pump to trigger the ventilator. Let me explain. In this cartoon, the entire lung is represented by pleura and the pleural pressure, the alveoli and alveolar pressure, the bronchi and the bronchial pressure. Now, normally at end expiration, all of those pressures are equalized and they are in and around atmospheric. Now, remember, this is a simplification. It varies where you are in the lungs, whether you're at the top of the lung or the bottom of the lung or the middle, the pleural pressure will be different. But for the sake of this example, I'm just keeping it really simple. So end expiration, atmospheric pressure is the same as bronchial pressure, pleural pressure, and alveolar pressure. To inspire, the diaphragm descends, pulling apart the pleural layers and generating negative intrathoracic pressure. That pulls on the alveoli, and then the alveolar pressure becomes negative compared to the bronchial pressure, which is negative compared to the pressure at the mouth. As a consequence, gas flows along the pressure gradient. If PEEP is applied, the entire airway apparatus is pressurized. So from the patient perspective, there is no difference in triggering the ventilator. They need to generate only a small amount of negative intrathoracic pressure to lower the alveolar pressure below PEEP to drive gas flow, having triggered the ventilator with standard flow-by settings. However, when there is bronchial obstruction or dynamic airway collapse, positive pressure is trapped in the alveoli at end expiration, and that positive pressure in this case is higher than PEEP. For the patient to trigger the ventilator and move gas into the airway, they need to generate significantly lower interpleural pressures to lower the alveolar pressure from the Auto-PEEP level below the PEEP level so that gas will flow. The patient will look like they are gasping and they rapidly become exhausted. As a consequence, after a while, the thoracic pump is not able to keep the pressure within the alveoli below the PEEP level and drive gas flow. The ventilator will not trigger and the patient will look really uncomfortable. If the Vsens is lowered to make it easier for the patient to breathe, it will not only not have any impact, it will have a lesser impact because the flow-by has dropped down. And so this makes it almost impossible for the patient to move air. The treatment is to increase the PEEP above the Auto-PEEP level. In this example, 10 centimeters of water. This now delivers a column of gas between the ventilator and the alveolus, and everything is now patent. Consequently, when the patient tries to take a breath, they only have to reduce the alveolar pressure a couple of centimeters of water below the level of PEEP to generate a gas flow with normal flow sensitivity. To summarize this, if the patient is struggling to trigger with Auto-PEEP, changing the Vsens doesn't work. You need to increase the PEEP. Now, this is very important because weaning from mechanical ventilation tends to be very prescriptive. Most institutions have weaning guidelines. There are international weaning guidelines. I would argue that every patient is different and they do need a different approach. But what every weaning guideline almost universally says is that you need to turn the PEEP down to 5 centimeters of water. This is not always the right thing for the patient. Remember that we use PEEP principally for oxygenation and for improving lung compliance. But the other reason we use PEEP is to overcome the waterfall effect with Auto-PEEP. So keep this in mind. Let's review this tutorial. In this tutorial, I discussed why patients fail to trigger. We talked about how flow triggering works and why flow triggering sometimes does not work. We mentioned IE sync as an alternative mechanism for triggering. Finally, I discussed one of the main reasons patients failed to trigger, and that is from the presence of Auto-PEEP. In this situation, changing the flow sensitivity or changing the way you trigger the ventilator will make no difference for the patient. The patient needs a higher level of PEEP that will get above the level of the Auto-PEEP, the waterfall effect, to ensure that PEEP is the same throughout the lungs. Once the airway pressure is the same throughout the lungs, then it's much easier for the patient to breathe. Next time, we'll talk about weaning. So that was patient triggering of the ventilator. If you enjoyed this tutorial, send me a like, subscribe on YouTube, and follow me at ccmtutorials.org.